unnecessary hospital utilization, whether we think about that in terms of emergency department utilization, hospital admissions, or hospital readmissions. There are a tremendous amount of data and evidence that shows that there is an opportunity here to think about shifting some of that care out of the hospital setting and into more community-based settings. This slide here is survey results from the Center for Health Information and Analysis that asked residents around their most recent emergency room visit in the past year. And across the board, approximately 35% of people said that their last emergency department visit was not for an emergency. And you can see here that while there is some variation depending on the income level of those individuals, essentially it pretty much is across the board around at least 1 in 3 residents reporting this instance. On the right-hand side of the slide, you can see why they reported. 57% said they visited the ED because they were unable to get an appointment, and 68%, more than 2/3, said that they visited because they were unable to access care after normal operating hours. This slide, helps us think about the opportunity in emergency department utilization, specifically for areas where there may not need that level of care. Would also add on top of this, and while I don't have the data here, we also know that behavioral health-related emergency department visits have increased at a pretty dramatic rate across the Commonwealth over the last couple of years. And in addition, based on some great work from CHIA, we also know that patients who have a comorbid behavioral health condition are much more likely to have a readmission back into that hospital. And so there are different populations that we may think about in terms of identifying an opportunity to provide better care in the community and hopefully avoid some unnecessary utilization, both reducing costs and improving care and patient outcomes. So this year, the Health Policy Commission wanted to look at a specific market trend that we've been noticing, and I think anyone who lives in Massachusetts and drives around on our highways have seen so many of the billboards and flyers around the expansion, the really exploding growth of urgent care centers. And so on this next slide, you can see we did a research work in determining where has this growth been over the last essentially 8 years? And we've seen a dramatic rise in the number of urgent care centers across the Commonwealth. We also saw a pretty significant increase in retail clinics, although as you can see on this chart, that has certainly leveled off in the last couple of years. And in thinking about what are the new roles that these urgent care centers are playing in perhaps filling a gap in our care continuum, we wanted to learn a little bit more about the services they provide, the role that they provide, and where they're located. So the first thing that we looked at on this next slide is on the cost of care. And so here we are looking at both all conditions as well as a subset of very low acuity conditions. And you can see from left to right the costs in the emergency department, the physician's office, the retail clinic, and the urgent care clinic. And as you can see, there are dramatic differences in the cost of care, both in terms of total spending, but also in terms of the out-of-pocket cost sharing that patients face. That's indicated in the blue bars here. Depending on the site of care that they're seeking this care. And so emergency departments, multipliers of costs when compared to a physician's office, a retail clinic, and an urgent care center. So this displays the kind of the dramatic variation that exists depending on the site of care. The next thing we want to look at is where are these urgent care and retail clinics being located as we've seen this dramatic increase. And so here on this next slide, we broke this down both for retail clinics and for urgent care centers based on the community income in which where those centers are located. And with 1 being kind of the lowest quintile in terms of community income and 5 being the highest income in terms of community income. And here too, you can see some variation in terms of where these what we call alternative care sites are located. And certainly on the retail clinics, more likely to be located in higher income communities. We do see a little bit of that same trend on the urgent care side, but it is not as dramatic as on the retail clinic side. We also wanted to hear a little bit more about this issue, so we asked some questions in our pre-file testimony about what do market participants think about the growth in these alternative care sites, urgent care sites, and how does it fit with their strategies for healthcare cost containment. And this next slide, I think, gives you a little bit of a flavor of some of the variation that we heard from the marketplace in terms of how they view some of these trends. I won't read all of these quotes, but to characterize, on this first quote, one market participant told us that while they see that there is a great need and that patients are utilizing their urgent care centers and they've seen utilization go up, they've not necessarily seen a corresponding decrease in emergency department utilization. The second quote here highlighted some concerns that some providers had around the fragmentation of care that may result if patients are not going to their regular primary care physician, but accessing care through some of these sites. But then would also note on this final quote, a really positive statement that they did see that these sites really were responding to patients' needs to access convenient and timely care, and that they were filling some shortages that may exist in terms of the ability for physicians to work after hours or on weekends, and did see it as more of a part of the care continuum as opposed to a fragmented piece. Finally, we also wanted to learn a little bit more about the patients that are being served by these types of alternative care sites. And so we did survey through our pre-file testimony and asked for a payer breakdown of both retail clinics and urgent care centers. And I should say, this is not every retail clinic nor every urgent care center in Massachusetts. This was a subset survey, and we aggregated these results. But they do include both kind of standalone urgent care center chains, as well as urgent care centers that are affiliated or owned by hospitals and other health systems. And what we found was that, and you can see here on the left-hand side of this slide, that payer mix broken down, and the commercial payer mix is indicated in blue. Self-pay is in the light gray, Medicare in the orange, and MassHealth in the gold. And in both the retail clinics and the urgent care clinics, at least by this subset survey, it does appear that they do treat a higher proportion of commercially insured patients than what we see in kind of the general healthcare distribution across Massachusetts, which is indicated on the right-hand side of this. Also interesting is there is a significant, not insignificant proportion of retail clinics that are truly in that self-pay category. So we wanted to provide these additional data points as kind of a launching pad. We are going to continue to monitor and track and understand the development of this particular market. But for this panel, really wanted to focus on what are those opportunities to provide timely, convenient access to care, not just for low acuity primary care, but also for behavioral health care services. So with that, I'm going to turn it over to Commissioner Cohen, who's going to lead us through this panel.
Thanks, David, and thanks for the additional information on the urgent care clinics. I think that's timely and important. So having learned our lesson from the first witness panel, I'm going to introduce the table. So we have, and thank you for being here. We have Dr. Timothy Ferris, Chairman and CEO of the Massachusetts General Physicians Organization, Tim. Dr. Jean Green, President and CEO of South Shore Health System. Manny Lopes, the President and CEO of East Boston Neighborhood Health Center. Ed Moore, the President and CEO of Harrington Healthcare System, and Dr. Christina Oreo, the Medical Director and Lead Physician at AFC Urgent Care. Thank you all for being here. As David indicated, a major focus of the Commission has been looking at reducing hospital stays and in particular ED visits. And really, an important strategy behind that is how do we enhance primary care access, and also, as David mentioned, the reference to increased behavioral health ED visits, how do we also improve access to behavioral health care, and how do we do it in an integrated fashion? So the Commission has spent lots of time, money, and energy on these issues, both with our grant programs, but also through our certification programs with patient-centered medical homes and ACOs. What I'd like to do is start by asking the panel, and we'll go right across, what are the specific strategies that each of your organizations are pursuing to enhance timely, convenient access to care? What are the barriers that you've encountered in doing that work? And what are some of the specific steps that payers, providers, and the state at a policy level could undertake to enhance access to timely primary behavioral health care for a variety of patient populations and geographies? And Tim, we'll start with you.
Well, thank you very much for those three questions. And I want to start off by thanking you for the commitment you've made to your work on the Commission and the incredible value that the Commission's work brings to the state, in part through the pressure it places on all of us to be better than we would be otherwise. So thank you for your work. It's very important work, and it's very valuable to, at least from my perspective, to the providers of healthcare in this state. So should I keep moving it away? So maybe I'll avoid that word. Let's see. What are we doing? First of all, what are we doing? What we're doing is in primary care is about three. Do you want to go? Maybe.
Yes, it's my magnetic thing here.
Yeah. It's about three things. One is changing, wherever available, changing the payment system, signing contracts that align the payment system with our aspirations for delivering care. The second is in primary care in particular, there's a big transformation that has been going on. Primary care now, I'm a primary care physician, it looks nothing like primary care from when I started practicing. And I'm going to read a list of abbreviations. All of these are very familiar to this group, but just to give a sense of the scope of what's going on. So patient-centered medical home. Sorry, I'm really not trying to do that.
No, you're right under the speaker. I think that's the problem. So
push it further away?
Yeah.
Okay. Patient-centered medical home is a very useful start. It's very important, the work that you're doing. It doesn't solve the primary care problem, but it's a really good jumping off point because it's evidence-based, and it gives CFOs a certain amount of important confidence that we're following a prescribed structural approach, which otherwise it would be a little bit like, well, we have some good ideas. So the fact that it is standardized is very useful. And most importantly to me, the patient-centered medical home, what it delivers is appropriate staffing ratios to get the work done, because primary care of the future is primary care based on a team where the physician is working with advanced practice providers, nurses, medical assistants, the whole team, in order to get the maximum value of primary care access and services to the patients that they cover. So patient-centered medical home is very important. The EHRs, pretty much everyone in Massachusetts, it's always been the leading state in the adoption of EHRs. We are starting to accrue more of the value of EHRs, and that is that we are using the registries that are built into EHRs to make sure that every patient gets their flu shot. Have all the commissioners had their flu shot, by the way? Okay, good, that's good, all right. Not everyone raised their hand, but we're close. So I know exactly which patients of mine have and have not had a flu shot, and I have someone, not me necessarily, to call them to make sure that we're doing just like we are with every preventive service, just like we are with all immunizations. The ability to do that in real time is an ability brought to us by EHRs. Care management and care coordination for high-risk patients. Telehealth and e-visits. We provided over 10,000 last year. E-consults. So 7% of all consults right now at Mass General Hospital are consults where a patient asks a person like me a question, and I ask the specialist the answer to that question through an email linked to the patient's record. They answer me back, and I answer the question to the patient. 7% of referrals to specialists, those are replacement, by the way. We've documented and published that those are replacement. So that's a huge decrease in ambulatory visits to specialists that are low-margin visits. Embedded mental health, and we'll get to the mental health stuff, but we've developed a program where we have healthcare workers and not necessarily licensed providers. Very often it is someone trained in behavioral health, but not necessarily a licensed provider, who is being overseen by licensed providers so that they are able to maximally disseminate the value of the licensed provider. And then very importantly, and finally, data and analytics. So all of this happens and can work poorly or can work well. And the only way you know if it's working well is if you have access to data that in real time shows you how well you're doing. And I would say, very importantly, the research that went into the CG CAPS data and all of the service-oriented metrics. So I'm sure all of everyone here uses these. These have become embedded in the delivery of care. I know precisely what my CAPS scores are, so does every primary care doctor at Mass General, because we see them twice a year. And we go through periods where we give incentives for improving them. So we measure access, the data and analytics provide us with all this. So it's a whole set of changes. It is not done yet, but it is really moving, and I see it moving inexorably in the right direction toward a real transformation. I will say I was here for the prior panel, and I did hear some frustration on the commissioner's part about where is the downstream benefit of that in terms of the access, in terms of the utilization. And, we're seeing it in our data. It is tricky because we're also introducing new things and new technologies at the same time. And in these gross analyses, it's really hard to pick apart when things are moving down and things are moving up, what the net is. Maybe that's some work that you could help us with. But I'm optimistic and encouraged that the work that's been invested in both the payment system and the infrastructure is actually making a real difference. It is slow, and I hear that, frustratingly slow, but it's making a real difference. Let me
Thanks, Tim.
stop there.
Gene?
I don't remember question 2 or 3.
Yeah.
I'm gonna move this.
Strategies.
Since it goes to him next, maybe this will help if we get less. Thank you for the invitation and the opportunity. What we're doing is we're taking a system and a consumer approach. So what we've been building over the last 3 years is a series of partnerships with the schools, the police, the firemen, the paramedics, the 911 service, and behavioral health services. We've tried and are starting to build what I call the community front door. The piece is every door you come through, you should be connected together, because part of the cost of healthcare is duplication and not knowing what's going on. Big help from the policies can be putting the head back on the body, because we need to see everything and we have regulations that keeps us apart, but we need to get through that. But we are now, with mobile integrated health and moving forward with that, our goal is to pick someone up from 911. A consumer does not know if they're in a true emergency. A family member does not know. So how do we get to that front line where decision making needs to be and make the proper decision through triage? So through telemedicine, telehealth, the paramedic can talk back to the ER doctor. They can say, you don't need to come to the ER. You can actually be seen in an urgent care center. So then we're going to transport. So then we brought the payer to the table because we need the payer to not say, it's not an emergency, we're not going to pay you, when the total medical expense is actually going to go down for the entire encounter. So we're talking about that. So we're going to be piloting a lot of these and actually have licensed clinical social workers embedded in the urgent care centers. As a primary care physician like my colleague here, we know part of the problem is doctors will not ask a question if it's going to open up something they're not willing or able to take care of. So we want to put in the system that says, you ask the question, do the screening, and here is the doorway for that patient, while you still need to go on and do what you need to do. So it's a lot of moving parts, but we are committed to it and to serve the community to make sure that it gets embedded throughout the community. The other part with that will be, the next part will be adding the preventive, the wellness, and also that other front door to come into the same kind of system of care.
Great, thank you. Manny, what's happening at the Community Health Center?
Manny, why don't you grab the other microphone while we figure out what's going on?
Okay, great. Thank you. Try this again. Can you hear me okay?
Yeah.
All right, great. Thank you again, and it's great to be here again. So a little bit about East Boston, if you don't mind me, because as a community health center, I know sometimes we get lost in the mix of the large healthcare environment here in the state. But as East Boston Neighborhood Health Center, we are one of the largest safety net providers in the country, serving over 90,000 patients, ranging from pediatric to geriatric care. What also makes us unique is that we also run a 24/7 standalone emergency department. And we've also been taking risk for the last 30 years within our PACE program of all-inclusive care for the elderly. Also, just finally, we are a founding member of the Medicaid ACO. Thank you to the administration for launching on this innovative model. Community Care Cooperative was founded in East Boston, and I'm happy to say we have 17 health centers who are owned and control the Medicaid ACO, and we're serving over 115,000 Medicaid lives. So in East Boston, we've implemented to ensure access, and I apologize for reading from my notes, but I want to make sure I get this correct, to ensure better access and outcomes for our patients and support a continuity of care. We've implemented an open access model within our primary care practices. In an open access practice, 70% of our provider schedules are now remain open for same-day appointments. 70% open for same-day appointments. This gives our patients access to the primary care team when they need it without conditions or qualifications for all types of visits, urgent care visits, complete physicals, and/or follow-up care. Shortly after moving into this model, we decided to incorporate behavioral health. So to reduce barriers and create parity, we expanded the scope of our open access model and included behavioral health care, adopting a model that was developed by Cherokee Health Systems in Knoxville, Tennessee. We have integrated behavioral health into primary care, and today our open access means that our patients have immediate access to not only primary care, but also a behavioral health care provider when they need it. This allows for warm handoffs from the medical team to a behavioral health consultant when a patient endorses symptoms of depression, anxiety, or substance abuse, or substance use. Our current level of integration means that we're somewhere between a level 5 and a level 6 on the federal HRSA, SAMHSA 6 levels of behavioral health integration. And our hope is by April of next year, we will move to that highest level of a level 6. By providing greater access to the patient's health home and providing whole person care, we have decreased our own ED utilization by 15% over the last 2 years. We have improved the quality of care for our patients, with 80% of our patients returning for follow-up care in behavioral health, in our behavioral health departments, and that compares to 30% nationally. We have eliminated the stigma related to behavioral health care by integrating behavioral health services into primary care. One door. We also have seen positive results from our patient experience, and I noticed there was a slide related to the patient experience, and adult behavioral health was at the bottom of the list in terms of patient experience statewide. I'm happy to report that 90% of our patients who get served at the health center would recommend the health center to a family or a friend. And finally, we're so excited about sharing this model, or having this model, that we're sharing this with all of our colleagues across the state and in the region. We've partnered with Cherokee Health System and have become a regional training center. And today, over 40 healthcare organizations have enrolled and completed the program and hopefully are adopting similar models.
That's great.
Thank you.
Thanks. Ed?
Thank you very much. First of all, thank you. Very pleased to be here today to be part of this panel and appreciate the opportunity to speak both about primary care and behavioral health. And I want to start off also with giving you a little sense of Harrington itself. For those of you that don't know Harrington well, just think of the crossroads of 84 and Route 90 and the traffic back up there on the weekends, and we're the next town over. So you must know it well when you see our sign on the highway. But more important than that, I was CEO there starting 11 years ago, and I think we've transformed ourselves from a small community hospital to a medium-sized community hospital, I like to call it, really understanding better the needs of our community. And our community is somewhat diverse. In Southbridge itself, it's a 40% Latino population with very little public transportation. We have about 25% Medicaid. We serve about 20 towns overall. Great need when I first got there for primary care and behavioral health. And by virtue of that, if we don't offer a service, since there really is no competition to speak of, they don't get it because they can't go elsewhere, and we feel very important that we provide that service. From the primary care side, I'll start with and then focus mostly on behavioral health in my comments to start. There was a shortage right off the bat, and when I got there, there was a dominant private medical staff who were aging and were looking to retire once the stock market turned around after '08. And clearly, that created even a further shortage, and we knew that we had to create an employed model. And we started with primary care and added specialists, and right now, we employ 85% of the medical staff. And without that, I don't think we can meet the access needs. We also moved the model to include more nurse practitioners and PAs to support a team concept and create more access through that venue. And it's really worked well. To the point of urgent care, about 4 or 5 years ago, we opened one in Charlton, super successful, had to expand it since, and created a second one in the town of Oxford, which is kind of the edge of our market where there were no physicians at all. We put them on the same EMR as our employed group, so there's good continuity there. And I would say the volumes that we're seeing in urgent care actually many days exceed the volumes in our ER. And to the other point, though, ER volume did not go down. It stayed pretty flat, though. So it's hard to predict what would have happened if we didn't open it. And right now, there are no other outside urgent cares in our market, and we believe it likely won't occur because the population base probably isn't strong enough to support more. Now, on the behavioral health side, I first want to thank the Commission and the Health Policy Commission because we've been the recipient of 2 very significant grants. The CHART grants all along, which allowed us to do many things, as well as most recently the SHIFT grant, which we're going to be using to provide Suboxone treatment in the ER for patients who come in, and more than a warm handoff, we will have the ability to keep them in the system so they get the care and treatment they need, rather than going out, not getting the referral, and then provide them the ability to help them not overdose again. And I think that's a huge way to really save lives, which is what our mission really is. I asked David to hand out, and I hope it's there because I won't have to talk as long, because a picture is worth 1,000 words, I hope, where you see the full continuum. And I know Dr. Secretary Sutters has seen this once or twice before at least. You see the full continuum of behavioral health services that Harrington provides, trying to integrate it and create many access points. One of the values of the CHART grant, besides all the coordination of care with social workers, was also helping us build the co-occurring disorders unit, which is a 16-bed locked unit, which I tell you, after a year and a half being open, most days it's full with 16 patients. The need is tremendous. We're the only one in Central Mass offering that kind of a service. If you go further, you see all the services we offer, and one of the things I think we're very proud of is through the continuum of care, we've been able to use case managers and through the CHART grant and decrease ER utilization of behavioral health ER visits by 41%. That's a significant improvement. And we're on to that, and we think it's critically important. We really have, in this, it was stated earlier, in our behavioral health model, we have psychiatrists as the key, of course, and nurse practitioner prescribers, but it's really a team where they have 4 or 5 social workers, licensed social workers, or mental health counselors working with them, so we could really make it cost-effective, but also more access for therapy and treatment. Our area is unique in the sense, as I alluded to earlier, where we really don't have an easy ability to attract private physicians. And to that point, I think we've done a lot on the behavioral health side, working also with the police, working on the court system. You see that on the chart. We were one of the first to have a drug court in Dudley, and now we've expanded it to Uxbridge and West Brookfield, as well as the school-based program. I think those are all critical ways to enter the community in a very effective way. Obviously, we have some barriers, which I'll talk, I'm sure, about after, with the way denials work and people understanding what we're trying to do and try to work towards that. And then finally, besides the Suboxone, I will tell you we're also excited about being part of the Medicaid ACO, working with BACO, Boston Medical Center. So thank you all.
Great, thank you. Christina?
So thank you for inviting me to participate in this conversation today. I'm quite happy to be here. I think it might be helpful to start with giving you a snapshot of what AFC Urgent Care is, where we are, and what we do. We're a series of urgent care in 21 locations in Massachusetts, and last year alone we saw 270,000 patients in the state. We treat high acuity, non-life-threatening illness for patients who are 12 months of age and older. And our model really focuses on quality care to patients, efficiency, and affordability. So in that vein, it's quite in line with the goals of this commission. We currently note that 30% of our patients don't have primary care physicians, and we hear that every day while in the clinic. And many more patients actually can't get in to see their primary care doctors. And so what we've tried to do, although we do not provide primary care services at this time, we're open to that. What we tried to do is develop close relationships with area hospitals in order to be a good access point for these patients. And we can get same-day and next-day appointments for primary care. And again, the word that's come up over and over today is access, and that's extremely important to us. We can provide care to patients at a fraction of the cost for the emergency department, about 1/5 the cost. And one of the earlier slides that was put up did mention that about 30% of patients that are otherwise seen in the emergency department could really have been seen in the urgent care environment for a fraction of the cost. And we believe strongly that we can increase access to mass health patients as well. So we do take all insurances, but one barrier, in answer to your question, that we have seen is the mass health restriction, the referral restriction. And so we get many mass health patients that come in and can't see their PCP or haven't been assigned a PCP. And for that reason, they're unable to be seen in our center, and then they need to be seen in the emergency department, and therefore that increases utilization. So lifting that restriction might be very helpful to us. Additionally, we don't have mental health services embedded in our centers, but given the relationships that we've developed in the community with both area hospitals and behavioral health centers, we are again an access point for patients to receive behavioral health care.
Great, thank you. Since I got all 3 of my questions in at once, I'll turn it over to my fellow commissioners if they have questions. Come on, Don.
Manny, what's the Cherokee model in a little more detail? And why did you choose it? How did you find it, and why did you choose it?
Yeah, so we learned about the Cherokee model, I believe it was about 8 years ago. Cherokee is a federally qualified health center, community health center, that actually began as a community mental health agency and brought in primary care. And they figured out a way to do that in a way that the medical provider and the behavioral health provider actually work as a team. So for many years in East Boston, we've had co-located behavioral health with the primary care, but it was still never felt like part of the team. They were located in separate areas within the floor, but really did not function as a team. And from a scheduling perspective, it was very difficult to do what's called as a warm handoff. So when someone in a medical visit presents with conditions that more appropriately for a behavioral health consultant to address, it was that patient had to actually reschedule an appointment and then come back, and of course that's where we've seen high no-show rates. I think I quoted 30% would return for that follow-up care. So Cherokee came up with a model that would really reduce that no-show rate, make the behavioral health provider part of that team, and come up with models, everything from technology models like using laptops instead of desktops, reconfiguring the practice so everyone's working in a team approach, and then also looking at some of the other challenges related to this, including reimbursement for the services.
Are there any regulatory or payment barriers to that, to doing it that way?
Well, if you do it the way they prescribe, there should not be. However, that warm handoff has to be to the behavioral health clinician, has to be a 16-minute visit. And that's the key to getting some reimbursement for that interaction. So I would list as one of the barriers, and I would say just generally, we look forward to a full primary care cap, and I know the Secretary and I have had these discussions where you can eliminate the fee-for-service completely and just allow the teams to work the way they should work for the patient.
David?
Thank you. So I was a little surly with the panel this morning, so I'll try and push you on the same question.
And I thought you were going to say, now you'll be really nice.
No, are you kidding? For an economist, that counts as nice. So like everything you're doing strikes me as amazing for patient care. Like the sort of, are the patients healthier? Are they happier? Are they living better? And so that's great. And then I keep wondering about the cost part. So like as of a few years ago, what we economists would always say is a ton of medical spending is used by people with very severe illnesses which are preventable. Some, not all, but some of which are preventable. And so we're spending a lot of money on people who just, if we dealt with them better, we wouldn't need to spend that money. So now here are 5 of you who are doing it better. And you've got evidence to show that it's better, and it's clearly better. And when we look at what's going on at Harrington, it looks better. And when you publish on MGH, it looks better, and so on. So why are we not seeing the cost savings? So you could say we were wrong, and you economists were stupid to believe that there were any cost savings there. Or you could say, just imagine what costs would have been if we hadn't done this. But what I'm just trying to square in my mind, the received wisdom, care for certain groups of people better and you'll save money, and the reality, which is I don't see it when Ray shows me the damn data. No offense, Ray, but
Thanks. I am not an economist. But what I'm about to say is I think, I believe, though I understand that it's somewhat controversial from the economic literature, and that is when I look at sort of, and I'm going to use round numbers because it's not a conversation about the exact numbers, but I think of the healthcare inflation as being twice general inflation over the past 40 years. I think that's roughly true. And I heard someone on the panel before say that, so 70% of healthcare costs are people, and the rest is the input costs. And so if the people, if 70% is going up at inflation, which one would expect over time, then just standing still means, and not doing anything differently in healthcare, means general inflation. So what is twice inflation? Well, to me, twice inflation is everything that has been invented in healthcare over the past 40 years. And that means every drug, every electronic health system, every care coordination system, everything that is not paid for otherwise. And I will say all of the things that we mentioned that we're doing, not all of them, but most of them, are actually cross-subsidized. They're not paid for on a fee-for-service basis. They're done using money from something else that does, and does it because it's the right thing, because you told us to, because like the list goes on and on. But so that's the heuristic that I use, which is, and so the expectation, what's happening now, according to your data, is we're now rising more or less at inflation. That is, but we're also doing all that new stuff. To me, that's a big victory, because the healthcare we're providing now is not the healthcare we were providing 20 years ago, and yet we're doing it at a rate of increase which is matching general inflation generally. I would say that's true over the past 4 or 5 years. So, I hear the frustration about not taking costs out, but I sort of think, getting all the new stuff that is coming out constantly in healthcare and doing that at inflation is actually I'll just say it, I consider that a pretty good thing, and something that we should celebrate. And the good news is, I think, like you, and I know some of you have published on this, I believe there is a lot more waste in the system. You talked about the 8%, one of you made a comment about the 8% administrative waste. I think we are going to, in the next 10 or 15 years, take out a percentage or two of that waste. And at the same time, we're going to be adding a percentage or two of all the new stuff that people keep inventing, like CAR T-cell therapy for cancer patients, that I think we want as consumers. Like, I think we want that new stuff. And so I think you're gonna force us, because it's the right thing to do, grow only at inflation, but it's also going to include all the new stuff.
I just added $1.32 million to my budget next year for one-to-one sitters for suicide ideation patients in my ER.
So the patients are sicker, and you have to.
So we're not getting them upstream. So we're spending money to try to get them there and catch them there, but we're not. So right now I'm spending on both ends of the curve. And until I get ahead of the wave, it's a problem. And the other piece is we have more people over 65 and more people insured. So, and we still say, every one of us, that there's not enough access. So we still haven't met the demand. Then we add consumerism, and consumers do not understand how sick they are. We need to really do a much better education on when do you need to be where. But at the same time, when you're afraid and it's nighttime and it's your mom, you just want help. So how do we also deliver the right care at the right time? I hate that cliche because it's overused, but is really what we need to look at.
And I know you've heard this answer before, and we keep talking about it, but this payment system hasn't really changed dramatically. I think it's heading in the right direction, and there are signs that we will get there, and I agree with my co-panelist here that things are moving in the right directions, and we are doing creative things. But until the payment system completely changes, and we're not living in two boats, and then there's another shift that needs to happen, which is the shift in the workforce. Because I do believe that we have some of the right people in the right places, but there are a lot of other folks that are not necessarily have to be licensed individuals. But today, it's the only way we get paid if they're licensed, or if they're doing a 16-minute visit versus a 15-minute visit. So the payment is an important factor of that. And then there's another investment in terms of creating and developing potentially a new workforce and retraining of the existing workforce. force, because a lot of what we're doing involves a lot of change management within our organization, and people have been practicing in a certain way for a long time. So to adopt this new way of practicing is going to take some time.
Yeah, still being a small independent community hospital has its challenges, and it has several factors that come with that. One is I spoke about the physician recruitment and the shortages, and one of the things that comes with that is the cost to find the doctor, recruitment. If you're short and you need them for call coverage, I have locums cost. If I don't have all the positions filled, like general surgery or orthopedics, essential services to my community, those costs are unanticipated much of the time. Having said that, we also have experienced about 2 years ago a very significant loss as a system. Remember, the hospital might make money with the numbers you see of that, but the doctor group that we employ loses money. Almost by definition, it's only a matter sometimes how much. When you look at both, we need to break even. That's our goal as a nonprofit. With that being said, though, when we had this significant loss, we took out about 10 to 12 million, about 10% cost out of our system in this current fiscal year going into 19. And I would tell you our rates are below 1.0, so we're not viewed as a high cost. And getting back to the earlier question about where care should be delivered, obviously I'm a big proponent that you don't need to go to UMass from my community for an appendectomy. I will provide it with the same quality at a lower cost, including up to cancer treatment, radiation, et cetera, because we have that capability, and it's good for access, it's good for the cost, and it's good for the community to have local care. What I would also add is, with the physicians, I have the same sitter issue, by the way. I don't think I have the magnitude of that number, but not far off. And while the investments we made in behavioral health help address those issues, as you see, but I think the challenge especially is if I might recruit and have 10 new physicians coming on in a short window. Those ramp-ups can kill you, because they all expect to be paid on day one with a competitive salary, and I don't see revenue for how long, either from a payment standpoint or a ramp-up of the volume standpoint. I would only end also with the drug costs are killing us as well. So I think we are making a lot of progress, especially with our payer mix that we're saddled with.
So from an urgent care perspective, I think very simply, healthcare costs represent a knowledge gap. And to Jean's point, patients really don't know where they should go in the middle of the night or during business hours when they have an acute condition. And I think this knowledge gap represents an opportunity for us to educate both health plans, patients, and providers, frankly, about what we can do in urgent care. So I say that because we can provide services at 30%, for 30% of our patients that would otherwise go to the emergency department and spend 5 times as much. So if we can identify that population and educate them, that's an opportunity to reduce healthcare costs.
Wendy, you had a question?
I did, different topic. So when Dr. Ferris did his opening comments, he talked about using telehealth, particularly e-visits, e-consults. I think you may have tele-ICU. And I think that is a direction we're going in to try to increase access both for regular care and for behavioral health. Although I will say I got my flu shot at a retail pharmacy, and my guess is you did not get the notice that I had my flu shot. So there is this interoperability issue still to be conquered as a barrier. But I didn't hear anyone else talk about the use of telehealth. So I'd be interested in a kind of lightning round if you would just quickly go through what are the barriers? Why are you not taking up and integrating and using some of these electronic or telemedicine innovations that we know improve access and reduce cost?
South Shore
Lightning round.
South Shore Care Now launched 10 days ago. It's an app on your phone. It's open to the public. So for urgent care visits that can be seen in a retail or low-end urgent care. We also have launched an internal for our own self-insured, a free urgent care for our self-insured employees as well. We also are using it in the field for the paramedics to be able to get back to the ER doctors. So we are using it in multiple areas. The interesting thing is the uptick in the community has been incredibly slow.
I would say that's our plan as well, as particularly in the behavioral health, is telepsychiatry. Today, we have 1.5 psychiatrists on staff, and they are available for curbside consultation and e-consult with the providers. So we're heading down that journey, but there's still a lot of work from a technical perspective, from a patient adoption and acceptability, particularly when a large number of your patients prefer to receive their care in a language other than English. So you have now interpretation challenges that go along with telehealth, as well as just adaptability, accepting that this is an appropriate way to receive care.
I agree. Telehealth is so necessary as an access point for patients. I think patients want it and will accept it. Currently in our urgent care environment, we're in the process of identifying and integrating a system that will work within our workflow.
Can I just say, add to the comment I made earlier, and just say that one important barrier is something that one might not expect. It's not like the payment system, although that is a barrier. There's a whole bunch of barriers. But one important barrier is the rate of use of this is sufficiently low with the uptake, even among patients who know it's available, because it's just not ingrained in their pattern of habits and thinking. But one of the problems is it sort of becomes a self-fulfilling prophecy. If you schedule physicians to do this work, you take them out of their regular, it's very difficult to integrate this work into, so a live patient, a video patient, a live patient, that turns out that is very challenging to do. But if you schedule sessions, it's a huge loss, right, from a payment perspective, because it takes time. So part of this is getting up to a critical volume of, and it is coming. It's certainly, there's, I would say the department that uses this the most at Mass General is neurology. My mother used to, who lived in Worcester, we saw her neurologist because she hated driving to Boston, so she would do video. But it was, and it worked very well, but it was a low enough volume that it really was not in the workflow of the physicians. I think what's going to happen is, as this increases, which it will, that we will reach a threshold where suddenly it becomes part of both what patients do and doctors do, and then it's really going to take off. But we just haven't reached that inflection point yet.
Yeah, just to round it out as a system, back on December 7th of 2009, Harrington was the first hospital that subscribed to the EICU with UMass. That was not owned by UMass. We do telestroke with them. One of our board goals this year is to really take a hard look at all virtual health. And in our psychiatric arena, as you see, our psych emergency team, which is in the center of that chart that we employ, they have to cover 2 ERs. And I think telepsych would be very helpful to cover the second ER, because it's much less costly than having 2 sets of teams in both ERs. So we're focused on that as an opportunity. And on the rest of it, of course, until recently, the third parties were not reimbursing, and if that's starting to change, or under a Medicaid risk model, I think it'll be very helpful.
Right.
Chris?
Questions maybe for Tim, but really for anybody, with regard to the impact of electronic health records. A subtle and hard to quantify impact on physician productivity and on the doctor-patient relationship is the data entry that inhibits the communication between doctor and patient. I don't know whether that's a 10% or a 20%, but everybody in the room would say that it's a negative, certainly in primary care.
I see patients every Thursday, and I finish my dictations this morning.
So, yeah. So that's a dramatic example. And there's doctor burnout as a consequence of those Monday to Thursday.
I also
put
think
offs,
it
but-
ties into why isn't cost, Epic for us was $172 million.
Yeah.
To build our new ICU was only a mere 60.
Yeah.
And then there's, after my ICU is built, it's built. I'm still paying user fees at an enormous cost. And then there's the upgrades, and then there's the connectivity, and then so all of this adds to your cost that isn't there. And then now that everything's going to the cloud, it's moving from CAP to OpEx because of the new rules. So all that goes into all of those questions combined. But patients don't like it because I'm looking at a computer instead of looking at them. And then the amount that I have to make sure I say and put it in the right place, because if it's not there, I didn't do the work. I'd love to be able to tell my plumber that. You didn't write it down, it didn't happen, I'm not paying you. And then if it's not in the right place, it doesn't show up on the reports, and then your HEDIS scores aren't right, and you still don't get paid.
So I think you've quantified the problem,
painful.
Gene. So, what, if anything, positive are you doing to try to get around this problem? And some of the fastest growing companies is Scribe America, where you have a human being on your shoulder, and there's artificial intelligence for devices now to take dictation. I mean, where's this going, and what are you doing? Is it a big problem? For Gene, it is, for sure. So what can be done?
Yeah, it is a huge problem. In this, I think technology in this case is the problem, but I think technology will also be the solution. And I see all those companies that are coming out with this stuff. We've embarked on a number of attempts to relieve the burden of our doctors, and we're doing a virtual scribe program. I actually stopped writing my notes about a year ago. I now am completely done when I walk out of my last patient, and the next morning all of my notes are written because a physician who listened to that conversation, all encrypted, wrote my note for me. It takes me maybe half an hour to edit my notes and make sure that they're all correct, and some things that I thought but didn't say out loud and need to get into the note and so forth. It has transformed my work life because I used to do 4 hours of practice and 4 hours of documenting. I now do 4 hours of practice and half an hour of documenting. That is a really big change. We've done that. We've made this available to all of our primary care doctors, and we're extending it now to our specialists. That's just one example of using technology to solve a problem that was created by technology. And I am optimistic about the AI. At some point, a computer will be able to take a transcript of an interaction and turn that into a half-decent note. I remember when computers started reading EKGs, the first time that those came out, they were wrong about 50% of the time. Now, it's very rare for those to be wrong. I think we're going to see the same thing in the evolution of EHR technology. It's going to become more user-friendly because it has to become more user-friendly.
Right. But I have a question for him. How does he cross-subsidize that?
Yeah.
Because that goes back to rate. I am sure I can't afford to give your doctors that.
Yeah.
In our environment, we've actually had a very positive experience with our EMR, and I think the way that we achieved this was to form a working group with our providers and really focus on our templates and find templates that all providers could agree upon. And that really improved efficiencies and satisfaction with the EMR itself. And so by the end of a shift, I would say 95% of our providers really have all their charts locked and they're done. And I think that's important for decreasing burnout and maintaining longevity in the practice as well.
And I would say for us, we've been running Epic now for almost 20 years. So we were very early adopters in the EHR space. So we've gone through the growing pains of, the provider productivity, the exam rooms not being organized in the way that it's patient-friendly, and we're still having those challenges today. But I do see that there is quite a bit of return because we would not be able to participate in value-based contracts without a mature, stable EHR to help collect the data and organize the data in a way that's meaningful. So I do think hopefully this will get better as there's more EHR adoptions, and that technology will provide a return on investment. But it is still painful right now, and we hear it from our providers that I think one of the significant issues that we're going to be faced with, and some of it's the EHR, some of it's the payment model, is provider burnout. And we have to solve this issue and really get them off that treadmill as quickly as we can and try to get them doing what they intended to do when they came out of med school and out of residency, which is touch, feel, speak to the patient, and look at the patients in the face. But right now, it is a challenge.
We have that provider burnout issue on the EMR as well. We have Meditech and Allscripts for the physicians, and quite honestly, I think we saw about a 25% less productivity when converted, and somewhat continues on. What we've done to help is hired a practicing internal medicine doc who is in the trenches, but also is the CMIO for the physician group. And I think that has rallied everybody to try to make the effort to standardize and help complete the notes appropriately.
I think we have time for one more question. Dr. Berwick?
Yeah, just quick, Dr. Oreo, just to change the direction a little bit. When David made his opening remarks before your panel, he showed us these data on a really very rapid increase in urgent care and retail clinics and no change in ED use. I just wonder if you have any view of that, like what's going on here?
So it's interesting, our clinics in Massachusetts are really all over in a variety of socioeconomic, demographic areas. I really do think there is a knowledge gap. I think there is an access issue that we can remedy if we do allow mass health patients to access our care without the need for a referral. And I think once that population doesn't utilize the emergency department for conditions they could otherwise be seen in our urgent care clinics for, that we will be able to decrease utilization.
Thanks.
All right. Well, again, I want to thank the panelists. This was wonderful. You guys really were very honest and open. Thank you so much. So we're now going to turn the program and allow public comment from a variety of individuals who've signed up. I hate to do this, but we do need to put time restrictions on your presentation. So we're going to be shooting for 4 to 5 minutes at the maximum. At 4 minutes, I will put my hand up just to give you a heads up. You can help me with the time.
I'm gonna help you.
And if you hit 5 minutes, Wendy's going to hit me, and I'm going to really get him. So with that said, we're going to start off with Representative Dennis Garlick. Denise, I'm sorry. Representative, it's a pleasure to have you.
Thank you very much. I was hoping you were all going to get a stretch break before you moved into this last lap here, so thank you for your
Oh, no, we're
patience.
just going to keep going.
All right. We shall all carry on. Good afternoon. I am Denise Garlick. I am a state representative from Needham, Dover, and Medfield. I have had the unique opportunity in my 7.5 years being elected on serving on all of our healthcare committees. I have served as the chair of the Joint Committee on Elder Affairs, and presently I am the chair of the Joint Committee on Mental Health, Substance Use, and Recovery. I have also, the greatest gift of my life has been to be a nurse, besides my good husband and my 4 children. And I have worked in union and non-union hospitals, in major teaching hospitals, community hospitals, the VA system, in a nonprofit center for adults with developmental disabilities, in a psychiatric hospital, and in an elite college, women dealing with healthy populations as well. I wanted to share with you three things. Number one, my position on the Safe Patient referendum. Number two, the history on how I believe that we have gotten to this place. Okay. Don't time me.
We'll take 2/10 of a second off that.
The history of how I believe that we have gotten to this place, and a metaphor that I'm hoping will be helpful. So I would like to share with you that, in my own experience, that what we know today is that people are bringing their loved ones to the hospital. I've been a nurse since 1975. In those days, when you brought your loved one to the hospital, you came with a sigh of relief. You believed that now your loved one would be cared for, and that there would be a nurse who was present, who would be available to that person and be able to deliver that care. And you went home and you finally slept, or you went to work, and you came back to comfort and to support your loved one. Today, I would tell you unequivocally that people come to the hospital with their loved ones and they are anxious. And they are concerned about who's standing at that bedside in the scrubs. They are concerned about when someone will answer that bell or not. They stay with their loved one for hours and hours, no longer just to support and comfort, but be sure that somebody hears that request for pain medication, that someone can reach out to the nurse when there is a moment of need. And so we have seen a fundamental change since 1975. I unequivocally support the safe staffing limits, and I would be fair and tell you that I have worked on this myself for 30 years. As a staff nurse going to Beacon Hill and asking for help on safe staffing, as a advocate for nurses, as the past president of the Mass Nurses Association, and now as a representative, having sponsored safe staffing legislation that a majority of representatives signed on to, and we were not able to get it out of committee. So what is happening? How did we get to this place where we know we have a really big problem and we don't have good strategies on how we're going to move forward on safe staffing? I know, and I know many of you know much more than me, but in the 1980s, in Massachusetts, it was the era of healthcare reform, and we had diagnostic groups that we were looking at, DRGs. At that time, the hospitals believed that the best way for them to deliver good quality care and move people quickly through the system with the best outcome was to supply enough nurses. And we saw in the 1980s that the hospitals hired nurses, they hired clinical nurse specialists, they beefed up their inpatient education for all their nurses, and what we saw then was, in my opinion, the golden era of nursing and the best patient outcomes we would ever see. We move forward to the 1990s, and Massachusetts deregulates the hospitals. We see a major switch in the focus. So now, in a belief that we're going to increase competition, decrease cost, and increase quality, what we really see is a drive for decreased costs. And we see insurers now driving the process as hospitals try to negotiate prices with the insurers that have the patient populations. They negotiate steep discounts, and now they have to cut costs. They have to cut costs so that they can meet the discounts that they've negotiated. The way they cut costs, traditionally hospitals cut costs through their labor budget. The most expensive part of their labor budget is nurses, and we see nurses being cut. Over and over again, nurses start to tell the stories. This is too much. They've asked for too many. We're caring for too many patients. We can't do this. And the nurses are told, and I would like to believe it's not gender specific, that's anecdotal information. We see that the nurses then begin to develop research, and you know better than me that the best research is coming out of the University of Pennsylvania. We move forward in Massachusetts in 2000 has a commission on nursing practice. The commission's report says that nursing is in a state of crisis in Massachusetts, and there are two recommendations: pass safe patient limits and ban mandatory overtime. We move forward, and in the legislature...
I'm going to need to
Okay.
slow this because we're running over.
Okay. So, but I'm got to get to the end of my story, Dr. Altman, because this matters. In the legislature, we see that the Senate passes safe staffing limits, but it doesn't come out of the conference committee in Ways and Means in the early 2000s. 2006, 2007, the House of Representatives passes safe staffing limits, and it doesn't get through the Senate because the hospital industry is so powerful and influential in the legislature and in this room. We move forward, and the nurses continually try to bring forward the safe patient limits, and more and more and more, the research backs that up. The one thing I wanted to say to you, and we come to the point of where we are now, right? There is no other option. There is not an avenue through the legislature. The problem is not getting better. It is only intensifying. I support the safe staffing limits because it is the only way that we can ensure quality care, and we know that the outcomes are bad. The Health Policy Commission has decided to
We're
put
gonna
their
need
thumb
to-
on the scale here.
We're really running way over.
I appreciate that. You've decided to put your thumb on the scale, and I want you to know that you have a mandate not only about cost, but about how you can evaluate value and how you can evaluate savings. And in doing that, I'm asking you to accept the responsibility for safe patient care, for quality care. The metaphor, which I will not go into, Dr. Altman, is the metaphor around climate change.
All right,
We
well,
knew
listen,
something was wrong.
I'm sorry.
That's fine.
This is, you're way over.
I appreciate
And I'm sorry,
that.
I wish
I am
we
the
had-
only
we're willing
legislator
to-
here, Dr.
By the way,
Altman.
we're willing to have this discussion in a very meaningful way with statistics.
Mm-hmm.
So trust us, we are not interested in any one side of this issue, but we do have to move on, and we have a
So-
number of other people.
so I have
It looks like they're going to be
detailed-
talking about the same issue.
I have detailed testimony for
Okay,
you with the
thank you very
statistics,
much.
but the
Okay.
story matters.
All right,
The
thank
story
you.
matters.
Okay, so our next speaker, and I'm really sorry, because left alone, I'd love to have this discussion in more detail. So
Dr.
our
Altman,
ne- but
I would
not-
love to make a
Yeah,
date for that, truly.
Our next talker is Donna Kelly Williams, who is the president of the Mass Nurses Association.
And Dr. Altman, I would never want to appear rude. I was told that there was not a time restriction when I prepared
Oh,
my
I'm sorry,
comments.
because I think we're pretty clear on that. Okay, sorry.
No worry. My name is Donna Kelly Williams. I am a bedside nurse for my entire career of over 40 years, and I am the president of the Massachusetts Nurses Association. I am here to comment on ballot question 1. Until this ballot issue, the HPC has developed cost estimates with a detailed and thorough review process, but this has been anything but that. This guess on cost resembles nothing that the HPC has ever done before. When examining the proposed BI-Leahy merger, the HPC refused to accept the data submitted by the hospital stakeholders and opted to, with broad input, create independent data for analysis. This did not happen here, and the public should receive an answer on this inconsistency. Your report was released on October the 3rd. We were made aware of the report, purely by accident, mind you, not even 2 weeks before that release. At the time this came to light, we were shocked to learn you had been meeting with representatives of the MHA, the single largest contributors to the opposition of question 1, the architects of the very patient safety crisis this initiative is trying to address. This process was hidden from the public. I'll draw specific attention to the HPC Advisory Board meetings on July the 11th and September the 5th, where ballot question 1 was discussed without any comment from any HPC official regarding any cost analysis. We've since learned from an initial response to our FOIA request that this process actually began on July the 5th when HPC issued an RFR for a consultant. The consultant retained was Dr. Joanne Spetz. That means for over a period of 3 months, the HPC had initiated a cost estimate for this ballot question, despite both public and private assurances that no such process was underway. But moreover, this cost estimate was generated by data provided by the opponents of question 1. Unbiased, independent data research, along with any differing viewpoints, were excluded from the process. When you are the one in the hospital bed and it comes to your nurse, do you want to be one of 4 patients or do you want to be one of 8 patients? In too many hospitals or in too many days and nights, it is the latter, and the risk to you and your loved ones is significant. Without adoption of this measure, hospitals will continue to provide vastly different standards of care. There is no method for holding hospitals accountable as a result of a fail to staff appropriately. And those actions, those choices, are not related to the financial status of the hospital, but rather they are simply a value decision made by hospital executives. This is a $28 billion industry. Hospitals can afford to make an investment in patient care. You are a state agency charged with oversight, and you will be responsible for enforcement of this measure. Enforcement actions against the very hospital corporations that you worked with to develop this inflated, inaccurate analysis. You have done a great disservice to the voters today, and by so blatantly siding with the opposition, you are complicit in an effort to continue to undermine the care and safety of every patient in the Commonwealth of Massachusetts. Thank you for your time.
Appreciate that. Thank you very much. Okay, our next speaker is David Multeodo, and a panel from the Massachusetts Association of Behavioral Health Systems. I'm sorry. Now, I don't know how this is going to work, because,
We have the same time limit?
yeah.
Okay, I'll do mine quick then. Thank you. My name is David Mattiotto. I'm Executive Director of the Mass Association of Behavioral Health Systems, and we represent 45 behavioral health hospitals throughout Massachusetts, all the way from the Berkshires to the Cape. We're very opposed to, we're here on question one. It's probably good timing. We're very opposed to question one. We are no on question one for 4 major reasons. One is the cost. Our cost estimates for this, if this ballot question for behavioral health alone would be, excuse me, $226 million to our system to hire the 900 nurses we would need. We have trouble now finding nurses. I have over 150 beds in the central part of Massachusetts empty because of staffing shortages. There is no way our hospitals in behavioral health can comply with the ratio of 1 to 5 nurses, which is in this ballot question. This question will devastate the inpatient behavioral health system in Massachusetts. And since we couldn't meet the ratios, we would have to downsize. There are 2,700 private beds now in our system. We estimate we would lose 1,000 beds because the hospitals would have to shrink in order to meet these mandates. I have had hospital CEOs of freestanding facilities tell me their whole operation would be in jeopardy and they may have to close. This is in a time where we're moving forward trying to meet the needs of Massachusetts. We've added over 300 beds in the last 3 years. We hope the public does not pass this measure. We know it's not before you to vote. We think your study is very accurate. We think for behavioral health, again, the figure is $226 million. We stand by it. We've run the numbers, worked on this for 6 months. We need 900 nurses in behavioral health alone to comply with this. So Marsha Fowler runs the hospital. She'll give you a little more detail.
Thank you for your time, and thank you for the opportunity to testify. My name is Marsha Fowler. I'm the CEO of Wormwood Health Systems. It's a behavioral health system that provides inpatient and outpatient care to folks seeking psychiatric and substance use disorder treatment. I did have the honor of serving the Commonwealth for 20 years, most recently as the Commissioner of the Department of Mental Health. From a global perspective, let me say what I've learned since starting as a mental health worker in a state hospital in 1980. I've learned that the healthcare system is highly complex. And when you make one unilateral decision, the unintended consequences of that decision can be devastating and far-reaching. The other thing I've also learned is that simply by adding more staff, it does not improve patient outcomes and it does not improve patient satisfaction. And from my perspective as a longtime health advocate, mental health advocate, we should be looking primarily at those 2 things if we want to improve the health system. How can we improve health outcomes? How can we improve patient satisfaction? Wormwood has been in business, continuous business since 1984. If this ballot question were to pass, the financial sustainability of our hospital would be in great jeopardy, along with all of the other freestanding psychiatric hospitals in the Commonwealth and community-based hospitals throughout the Commonwealth, particularly those in rural areas. For example, if this ballot question were to pass, say on a 20-bed unit, I would have 4 nurses 24 hours a day around the clock, including 11 to 7, where basically no hospital administrator would make a decision to have 4 nurses on a 20-bed unit while everybody's sleeping. I mean, it just defies logic. Is that my time? Okay. While I'm standing up and getting ready to go, there's a number of things that I can say about this. In addition to, we do not have the staff already to meet the capacity needs of our hospitals. We have empty units across the state. It's financially sustainable. And the people that will suffer the most are those that have public insurance. The rates are very low. Many health providers do not want to take that population to begin with. As a Commonwealth, we have a responsibility to vote no on this ballot question. It's not acceptable for the Commonwealth of Massachusetts to have the cost of this on the backs of people on Medicaid and Medicare, because those individuals will be priced out of the healthcare system.
Thank you very much. Appreciate it. So our fourth speaker is Joe Carrillo from the United Steelworkers, President 12003. Joe? He left. Okay. John Bunapane, also in United Steelworkers? Okay. Cynthia? You've been here for us before?
Some updates. I did pre-prepare, so I will be under the 5 minutes for sure.
Okay.
Thank you very much for having me. I'm Dr. Cynthia Champel, and while I wear many hats, I'm here on behalf of Stop TB Massachusetts. It's a group of tuberculosis experts and advocates for TB elimination and an affiliate of Stop TB USA. We are pleased to respond to the request for testimony on healthcare cost trends in the Commonwealth. Just in the last year or so, Massachusetts has suffered a double-digit increase in tuberculosis, a serious hepatitis A outbreak, enhanced risk of West Nile virus, a massive fentanyl-related HIV and hepatitis C outbreak, steady increases in syphilis and chlamydia, an alarming spike in gonorrhea, including drug-resistant gonorrhea, and the introduction of 2 new tick-borne diseases. Our daily reality reveals infectious diseases in old, new, and drug-resistant flavors are increasing our suffering, avoidable ED visits and hospitalizations, disabilities, and healthcare expenditures. Moreover, every healthcare provider relies on our public health infrastructure for one type of a support or other, from diagnoses to disease surveillance to outbreak management. The list really is too long to cover here. TB requires special attention because of its incredible complexity and expense. However, TB also offers insights into the benefits of preventive efforts and the huge costs of neglecting the same. Quick refresher, TB is caused by a mycobacterium spread by breathing air. The disease is preventable as well as curable, although there are serious side effects such as permanent loss of hearing. TB is the leading infectious killer in the world, and it claims more lives than AIDS and malaria combined each year. Back to the matter of health costs. Increasing generic drug prices highlighted in this hearing this year are of especially grave concern in the case of infectious diseases because the population, rather than the individual patient, is subsequently impacted. In 2016, the price of cycloserine, a decades-old specialized antibiotic, was increased by 300%. Cycloserine was the 4th anti-TB tool affected by price increases in as many years. This particularly impacts Massachusetts because 1 in 4 of our active cases are drug-resistant to something, and we have nearly triple triple the national rate of extremely complicated cases, so-called multi-drug resistant TB cases. A course of regular TB will cost us around $40,000. A case of MDR TB will cost us between $250,000 and $1.3 million each. We are losing ground currently. As 2017 saw a 10.5% increase in TB cases and 2018 shows no sign of decrease. We have also just this past year lost 4 TB clinics that operate as public-private partnerships. Perhaps in response to Commissioner Cutler's question earlier of if you put pressure, what do we lose? I think we're seeing some of this right now in the loss of 4 TB clinics out of 18. Years of budget cuts and subsequent reduction in trained personnel have resulted in diagnosis delays and an increase in the reservoir pool of TB infection, estimated at about 300,000 persons in the Commonwealth. The only real progress against the primary source of active TB disease is in the Lynn Community Health Center's innovative model for expanding TB prevention services within the primary care sector and even beyond into the community with a special CDC grant. This program is also a great example of greater integration of public health and health sectors with increased coordination, competency, and capacity. Third, increasing costs to families is of special concern where infectious diseases are involved. It's long been documented that out-of-pocket charges reduce acceptance of and completion of TB and TB infection treatment. This is a recipe for outbreaks that cost New York City, for example, $1 billion in 1991. To avoid further such incidents, such as TB outbreaks in Massachusetts, or just letting the infectious diseases get out of control, we recommend the HPC take concrete actions to strengthen prevention, including, in all of your efforts, reports, research, please consider the impact on population health in the public sector. To the extent possible, explore and encourage further integration of a shift to population health improvements, where life expectancy gains are much more.
So if you can just summarize.
I'll wrap it up. Urge the legislature and the administration to increase investment in infectious disease infrastructure and personnel. And third, work with the administration to urge the NIH to protect public interest, particularly in the case of medicines essential for public health. For example, using the powers it has with the 1980 Bayh-Dole Act. Thank you.
Thank you so much. You've made some very good points, so thanks a lot. So our final speaker is Susan Fendel, who is a senior attorney for the Mental Health Legal Advisory Committee.
Thank you for having me. Our agency represents low-income people with psychiatric challenges throughout the Commonwealth. We're an agency under the Supreme Judicial Court of Massachusetts. I am here to talk about payment reform and how payment reform, delivery reform has unintended consequences, as well as some alternatives to reduce prices and improve quality of care. Managed care of the 1990s didn't work. It resulted in cuts in care without improvements in quality, in fact, deterioration of quality of care. We know that pay for performance has not worked. And I would suggest that putting providers in the place of insurers by putting their financial interests at risk is a terrible idea. Outcome measurements are supposed to control the incentive to cut costs, but outcome measurements are crude. They can be gamed. It causes cherry picking. And I myself have experienced how they can be gamed. I was in a bicycle accident. I was in the hospital for 3 days, and I was never admitted. So that affects admission rates. I think we also know that shifting costs to consumers is not a good idea. It causes people to cut pills in half, reduces care, And in addition, we saw this morning how low and moderate income people are stuck with incredible medical debt as a result of shifting costs onto them. Care delivery, integrated care. It is the fad now. However, I would suggest that if you look at the studies, there is very mixed results with respect to both prices and costs and outcomes. Very often the studies do not account for confounding factors, such as at the same time the delivery system went to integrated care, they also added staff, or they changed some of the ways that they provided particular services that can be provided without integration of care. In fact, most doctors relate to one another not because they're in the same system, but because they use the telephone, or they use email, or they use faxes, but not necessarily because of integration of care. I think for our clientele, there's something very important that needs to be looked at with integrated care, which is the fact, supported by numerous studies, that implicit bias against persons with psychiatric diagnoses and psychiatric challenges causes people with psychiatric challenges to receive fewer services and interventions than other patients. In fact, diagnostic overshadowing is common, which causes delayed diagnosis and hurts the care of individuals with psychiatric challenges, contributing to the 25-year earlier mortality rate of people with mental health issues. I applaud the Health Policy Commission and Speaker DeLeo for recognizing that social determinants of health need to be addressed. However, I would suggest that because insurers benefit in terms of reduced costs from the provision of things like housing, that they should contribute to the cost of social determinants of health. It is not effective for insurers or providers to refer people to public benefit programs that are underfunded, like housing, and cannot be provided to too many people. In fact, Housing First, by the way, is one of the programs that has been shown to reduce healthcare costs significantly.
So if you could summarize.
Okay. And finally, alternatives like peer respite reduce costs, and most of our clients would prefer it. Same thing with meditation, companion animals, and service dogs, which have been shown to help vets who have PTSD get off medications totally, and we know that medications are a big cost driver. And also encouraging social interactions and exercise. So we hope you will look into alternatives of care as opposed to some of the more draconian cost-cutting measures. Finally, this is the very last thing.
Okay.
Mental Health Legal Advisors Committee usually does not take a position on ballot issues, but I do want to point out that where the studies show that where there is a higher number of nurses in hospitals, there is a lower incidence of restraint. And that is a significant issue for our clientele.
Thank you very much. Appreciate it. Okay, very good. I think that is the list that we have. So I want to thank everyone for coming. We're going to start tomorrow at the same time? 9:15. Oh, okay. 15 minutes later, okay. And we look forward to seeing everyone here tomorrow. We're going to have a very productive and interesting set of panels. Thank you.
Yeah.